Good morning, everyone. This is the last presentation of the day. My name is Sean Gibson. I'm a second year resident here. Just want to, first things first, give a special thanks to the Social Lecture Group. Good shout out to Dr. Sklar and Dr. Adrian for helping me out with the slides and whatnot. This is a very important topic. I think, we all have a lot of reasons as to why we chose Kings County, SUNY Downstate to train. And the patient population that we serve and just the environment that we're at. And in all actuality, is a very important topic, and addressing racism in emergency medicine. This is something that I want to actually have as a lecture series throughout my duration of my residency here. So I entitled it Chapter 1, Individual and Organizational Strategies. So we'll begin first with connecting the theme of the theme within the conference, which is the disasters and why is this important. So disasters and health inequities in New York City. It's sad that every single like disaster that comes to New York City will affect communities of color disproportionately and relative to other communities. Here we see within this figure when we actually compared the COVID-19 impact on African American communities of color, 22% of the NYC population is African American. However, 28% of the COVID-19 deaths in New York City were impacted by 28% of African Americans. We go on further towards other communities of color. More specifically, we see here race and ethnicity amongst Hispanic, Black, white, Asians, and others. 34% of the New York City deaths were taken afloat from Hispanics, while Blacks were 28%. Yet we see the population, once again, 28% of Black deaths in comparison to 22% of the population. Hispanics, 34% deaths in comparison to 29% of the population. So we see here that stratified data in the earlier months of COVID-19 highlighting the total deaths to population amongst the community of colors, the ones that we primarily serve. So now we shift gears onto a different disaster, if you will, in 2013 with Superstorm Sandy, with how it affected different areas of New York City, specifically within this area, within Far Rockaway, within the Rockaway beaches. So within two different sides of the island, you have one island that's primarily African Americans. 10 years later, they're still going through effects of not getting the revamp, reconstruction, and just bad rebuilding after the Superstorm Sandy. And then we have an NYU expert here, Dr. Jacob Faber, that says you have these geographically and socially, economically isolated communities that are just in a position to constantly get hammered over and over again. So this is very important in a case where we serve a very vulnerable patient population. And a lot of that comes down to different efforts within redlining and other oppressive methods that primarily targeted these communities. So we transformed that now back to the COVID-19 pandemic, and I'm pretty sure I'm preaching to choirs at this point. I was personally still in school and during the pandemic, so I know a lot of people on this Zoom call were actually frontline heroes within this, but just knowing the inequities amongst the hospitals. So here we have on the top left, Elmhurst Hospital, which serves the very vulnerable population in Queens. And then on the bottom right, we have our very own Kings County, where you all have saw the differences amongst resources and funding amongst different hospitals and whatnot. So once again, going back to the theme of today's conference, it's sad that every disaster that comes to New York City will affect communities of colors disproportionately. Understanding that, acknowledging that as Kings County EM docs will make us better doctors in the future, and shift by shift on addressing what our patients go through within that. So just to bring it up to speed with today's agenda, as I said, this is a series lecture that I want to have throughout my course of residency, but first things first, we're gonna welcome everyone and pretty much introduce the individual level strategies that we all can do together to recognize and address implicit biases, allyship and guiding conversations in the ED or outside of the ED, but just welcoming conversations that need to be had for us to become more aware with the racism amongst emergency medicine and just medicine in general. And then we'll also speak about the organizational level strategies, what our admins can do, what our program leadership can do to help build workforce diversity. And then the final basis of today's lecture is connected it back home to us and why this is an important lecture for us to continue to have as chapter 1 and chapter 2 and chapter 3 in the future. Just some learning objectives for today's presentation as well. So firstly, we all want to understand how racism and health inequities affect our patients, but let's actually extend it further to colleagues of color. It's not just, obviously we're in it for patient first, but how are we going to be a good colleague for our colleagues of color who, as we'll see throughout this presentation, has some obstacles and struggles within ourselves as well. Secondly, recognizing ways that we all can give support for our patients and colleagues. This may not really apply at goal within our emergency department here, but when we all go off to the great places after residency, knowing how to be that supportive role and figure as an ally is something that'll make us all better doctors and humans in general. And lastly, identify ways that leadership can have programs geared towards diversifying our workforce. Right, so we're going to start off with number 1, the individual level strategies. And then, as I said, we're going to focus on 2 points for this lecture: recognizing and addressing implicit bias, and allyship and guiding conversations. And you're probably like, Sean, what exactly is individual level strategies, right? Who does that really apply to? Our responsible parties here is going to be EM doctors like all of us, nurses, paramedics, medical students, and the ED staff. We have to understand that when we have our medical students come in with us, we have that ability to really make that impact and difference then, not just telling them just get the IV and go for, mindless tasks such as pushing them to a CAT scan, but really embodying and really setting the fundamentals within how we can all be better as they enter medicine. So this is exactly what the responsible parties for individual level strategies that we're going to discuss. So first things first, implicit biases in healthcare. This is a great chalkboard figure, pretty much step 1, interpersonal interactions. What does that mean? Unconscious biases influence your interpersonal interactions between the patients and the doctor. And in the next slide, I'm going to show what exactly some medical students at a university actually think about pain perceptions amongst Blacks and whites. But understanding that your unconscious bias may actually influence how you actually clinically think about what the patient may have and what pain management you're given to said patient. Step 2, internal dynamics. Once again, understanding that your implicit biases can also influence the internal dynamics that you may have with your colleagues or staff. I remember in a previous conference when it was a lecture given on how to attain feedback. One of the struggles mentioned was the race dynamics as well too. So understanding that the person that may be evaluating you may have some type of subtle like biases towards giving your evaluation. That's been something that's been proven with many different articles and whatnot. So just understanding that still plays a part in here in 2024, where everyone is so quick to say, I'm not racist, I'm not prejudiced, but understanding that implicit bias can definitely play a role into that. Step 3, for our economist out there who loves money and whatnot, understanding that there was a 2011 paper that revealed that racial health inequities resulted in about $310 billion of a loss. And then a lot of that is due to fetal demise within the Black maternity health outcomes and just different outcomes within health and inequities, specifically for communities of color. So just being aware about um, the I guess the whole idea of what implicit bias can do within healthcare, and then the negatives it can also bring. So this is the article that I want to introduce to you all, where medical students and residents at the University of Virginia had false beliefs in pain assessment treatment amongst Black and white patients. Pretty much, there was a study that suggested that the disparities amongst pain management may be due to bias, where a substantial number of white medical students and residents had false beliefs about the biological differences between white and Black people. Some examples there were that some actually said that Black people's skin were thicker, and Black people's blood coagulate quicker. So I just want to pose a question to you all based off of that information. How do these beliefs affect how these providers may assess and treat pain experienced by Black patients? I think the beautiful thing about our program is very diverse. We have a very good, diverse attendant faculty residents as well too. But once again, understanding that UVA is one of the top quote unquote top 25 medical schools in the country. This is how medical students and residents at that institution perceive the differences amongst Black and white patients. Just something to think about. Now we try to fast forward now to ways to actually combat these implicit biases. So we see here in our legend that blue is embodied by both in terms of individual and organizational. For this subsection, we're gonna really focus on the green, which is question actively and encounter stereotypes as well as self-reflection on personal biases. But pretty much this figure just highlights ways that we all can pretty much really combat these unconscious biases. So now we transfer forward 6 ways to combat implicit biases, right? So as we said with the whole theme with educating ourselves, practicing mindfulness, being aware of your thoughts, acknowledging that we all have some type of implicit unconscious thoughts, diversifying your network. I think this is the beautiful thing about where we train, where it's just like we all are coming from different backgrounds and we all emerge within it as one family for us to have these diverse thoughts. I remember always speaking to a couple of ED staffs and nurses, and they say, wow, like it's just so cool to me how you can have a non-Haitian speaking person speak Creole with our patients. I'm just seeing that cultural diversity amongst us as ED residents and attendants and whatnot. So diversifying something and diversifying our network is something that we have positively here. But then also challenging the stereotypes, speaking up against stereotypes within the media and in daily life. We definitely have aspects upon that there's always some engaging conversation on shift with some type of issue, that's whether it's going on within our own borough or within the media. Slowing down your implicit steps to make an important judgment. This could be something whether you have a critical patient in a trauma unit, really taking your step back and really assessing what's what and not just going off of what you would want to do off of any implicit thoughts. And then lastly, the perk that Esteban said during this intervention and what was given on Sunday, the implicit association test. So, I'm not going to scold you all like my kindergarten teacher used to do to me if I didn't do the homework assignment, but just understand that this is something that we all should do on our own. And just knowing that these are the results of that specific race IAT. So as I said, this is the breakdown of the results that everyone received on Sunday. The purpose of this isn't to verbally raise your hand on Zoom and share your results with your colleagues or friends, but it's to really understand your implicit biases and recognizing what your results may have been and finding ways to combat that, to become better EM docs, as all of us want to be. And, really, this is really the first step with recognizing and combating and becoming a better, more versatile EM doctor. So now we're going to change gears within the individual level strategies to being an ally in the ED. So what exactly does that mean? And an ally understands their own privilege and pretty much understanding their own privilege in the conversation about race. Becoming an ally is an intentional quest that requires active learning and accepting criticism and being comfortable with being in uncomfortable discussions. Being an ally requires speaking up and supporting marginalized colleagues, marginalized patients, and understanding by not speaking up during these uncomfortable settings, we continue to perpetuate the trauma of racism within medicine, but specifically within the ED as well too. And pretty much this figure really highlights what allyship is. It's truly a journey. As with anything else in life, we all got to where we're at on our own journey. We didn't just go from high school to becoming an MD. We all had a journey to get to where we're at right now. In the same aspect, allyship is that journey to recognizing and combating the implicit biases, also recognizing self-reflection and building relationships, and taking that action and being that advocate that we all can be. Now we're going to switch gears again. We just spoke about the individual level strategies. Now we're going to speak about the organizational level strategies. And as I said, this is chapter 1. This is the first presentation of a lecture series that I plan to continue on through our residency. Now we're going to focus on building workforce diversity. Responsible parties in this aspect is going to be our APDs, our PDs within academic medicine, urgent care hospital admins, the AAMC, SAAEM, and all of these organizational platforms to help address racism within emergency medicine. So first things first, is important to actually say why is building workforce diversity important to begin with. So here in this figure from the AAMC, we see the current gaps in representation in US healthcare. 64% of doctors are male, 56% are white. We look on the bottom left, 6% identify as Hispanic, despite this group being 19% of the population. We look in the middle, only 5% identify as Black or African-American, though 13% of the population is Black. This really cries out that we need to really diversify medicine all in all. There's efforts already made organizationally wise by the AAMC in 2021. They actually have this project Diversify campaign where they're pretty much encouraging more so for my minority applicants and admission within medical schools through various different platforms, whether it be pipeline programs, etc. One thing that I will really credit our program specifically with as well too is that we have those programs as well, being through different programs like MMSEM, which I've actually went through. And I think Camilo as well too, and then other residents within our Kings County EM went through those programs to really help diversify our workforce here, but knowing that there can be more that we can do. So pretty much this slide, as I said, diversity in healthcare improves patient care outcomes. There's a lot of articles that pretty much confirm that statement. Current plans, as I said, such as pipeline programs, mentoring programs, scholarships for underrepresented minority groups are great steps. Once again, steps that we're making here with really increasing that within our residency program. I think this is now a question towards Dr. Youssef, if he is on this call with, what is that next step past residency? How can we build a stronger workforce diversity amongst admin within the health hospital admins and whatnot? So, this is not anything to target anyone. This is just a conversation for all of us, just to really grow together, and just to really see how can we continue to build this workforce diversity to really reflect the patient population that we serve as well too.
So, hi, can you hear me, Dr. Gibson?
Oh yes, oh Dr. Yusuf, yes
Hi,
sir.
yes, pleasure. Just to be very transparent to the crowd, Dr. Gibson did not throw me on the spot here. He and I actually had a great discussion about
Okay.
his lecture yesterday, and uh, I promised him that I would join, and he reminded me. So, thank you for that. I believe one of the most important things that we can do to really affect healthcare equity is to actually have true representation in the leadership structure that reflects that of not only the patients that we serve and the community we serve, but also the trainees that we're educating, as well as the rest of the workforce. That's that has really been our approach. I'm extremely proud of the representation throughout our leadership team. Let me step back a second. Approximately 3 years ago, I attended a lecture where, there was some interesting data demonstrated where despite more than 50% of the workforce in emergency medicine and healthcare being females, the representation of females in executive leadership positions was actually quite low. The number quoted was less than 15%. Then McKinney ran an extra analysis where they demonstrated the representation of females had even greater disparity when looking at Black females and Latina females. So, there's ways that we can impact healthcare equity, and I've attempted to do that, directly through our hiring practices. I'm very fortunate to have Dr. Che, who joined us from Northwell and has an executive MBA, Dr. Hope Tate, who is also the second base of that triangle, Dr. Aganor, who's running Brooklyn SART, and so forth. But let me be very, very clear about one point. None of these providers were hired because of gender, race, background, or anything. They're hired because they're exceptional candidates. The one thing that has been lacking in healthcare is the appropriate support for these candidates and encouragement to move on to higher levels of leadership. And that's how I've been approaching my position. So I'm willing to take any questions. Dr. Gibson, I hope I was able to adequately answer the question and open up the discussion further.
Thank you, Dr. Yusuf. Yes, sir. Yeah, and I mean, we could all have this conversation more after at the end of this presentation or even on shift, but just for sake of time, I'll just continue going on. This is the last subsection of chapter 1 of this presentation. Why Kings County and downstate EM, right? So we all had our reasons as to why we wanted to come back, or why we wanted to come here to begin with, pardon me. Serving underserved populations, learning from cultural backgrounds, becoming a better person / human. So once again, thank you, Esteban, for your how to give a good lecture talk earlier. This is a little tip now. So interaction with you all right now, and put in just a little verbose screenshots of actually why did we choose on coming here. So whether that's becoming that bad A $$ EM doc who strives to improve the lives of people within your community, and just pushing you to become a better person, whether that's looking for a county program that would challenge you every day, clinically pushing you out of your comfort zone, being amongst a patient population with a wide variety of cultural backgrounds and growing as a human, whether that be looking for a place to be happy, also looking for leadership that would prioritize your well-being, but becoming a good person outside of the ED while being passionate about social justice and providing medical care to underserved patient populations, while just really, the reputation of grit and the cultural diverse patient population that we serve here. We all had our reasons as to why we wanted to specifically come here. I think now is a great time where we could realize the impact that we truly have just being here. This may be a 4-year contract for a lot of us, but the experiences and conversations like this just makes us better EM docs, just makes us better humans in general. And it really addresses the time is now, which is the responsibility to really address the racism within medicine that we all know from historical complex contexts, pardon me, but then also knowing how we could address that here in the ED. So the basis of this presentation and this lecture series comes from this 2021 article from some EM docs out of Emory University, understanding our roles and responsibilities as EM docs. Is just so much more than putting in orders, and understanding that we really have the ability to change the culture and the dynamics within EM one shift at a time. So what exactly are the next steps? This is a figure from that article as well too, that pretty much highlights different roles within individual, organizational, community, and policy. Throughout these next 3 years, I graduate 2027. Pretty much just these series will really allow us to have these conversations where we'll pretty much speak about the individual, organizational, community, and policy effects, specifically with how we could make our program here better and how we can make ourselves better to really be who we all want to be as EM doctors. Another next step is I have the honor on actually being one of the co-chairs for the Diversity Equity House Staff Council this year. Last year was Pierre and another PEDS resident. I know that this was sent out, but this is another subtle, push to get some residents and faculty participation for our upcoming virtual residency recruitment fair, understanding that our words and how we present our programs really make a difference within who's coming into our family. So understanding that we don't necessarily have to start that on the 1st of July every year when we have residents or interns coming in for orientation months, but it starts physically whenever we have medical students, whenever we have that ability to make that impact. So you all can, if you're free, please sign up. These are the references for today's conversation. Once again, this is a continued lecture series, and questions and a QR code.